We're going to move right along to the next talk. This is going to be high mortality and venous thromboembolism risk following major penetrating abdominal venous injuries, presented by Dr. Haqqani from Boston University Medical Center.
Good morning, everyone. My name is Maha Haqqani, and I am a PGY2 General Surgery resident at Boston Medical Center. My co-authors and I would like to thank the Society for the opportunity to present our work today. The title of my presentation this morning is High Mortality and Venous Thromboembolism Risk Following Major Penetrating Abdominal Venous Injuries. We have no disclosures. Injury to the inferior vena cava and or iliac veins is more common with penetrating than with blunt trauma and has been shown to be associated with poor outcomes, with mortality rates ranging from 20 to 70% for IVC injury and 17% for isolated iliac vein injury. Additionally, traumatic venous injuries are independently associated with increased risk of venous thromboembolism. However, the association between penetrating iliocaval injury, venous thromboembolism, and mortality has not yet been established. Our objective, therefore, was to examine the association of penetrating iliocaval injury with venous thromboembolism and mortality. In order to achieve this, we carried out a retrospective review of records in the National Trauma Data Bank from 2015 to 2017, using ICD-10 codes for penetrating intraperitoneal and retroperitoneal trauma. Exclusion criteria included age less than 18 years, missing admission data, patients with no signs of life on arrival or who died during transfer to the facility, and patients who died in the ED. We defined our exposure as the presence of associated iliocaval injury. We compared baseline characteristics, including demographics, risk factors for VTE, and injury characteristics. Our primary outcomes were in-hospital venous thromboembolism, 24-hour mortality, and in-hospital mortality. Our secondary outcomes included cardiac complications, acute kidney injury, extremity compartment syndrome, unplanned return to the operating room, and hospital length of stay in days among survivors. We also built multivariable logistic regression models to examine the independent association of iliocaval injury with VTE and mortality. After applying our exclusion criteria, we identified 9,984 patients with penetrating intra-abdominal trauma, of which 329 patients, or 3.3%, had iliocaval injury, and 9,645 did not. Crude demographics showed that iliocaval injury patients were younger and had minor differences in race distribution and BMI. We also compared medical comorbidities between the two groups and found statistically significant differences in the rates of hypertension, diabetes, and current smoking, all of which were more prevalent in the group of patients without iliocaval injury. When analyzing risk factors for the development of VTE, we found that iliocaval injury patients were comparable to those without iliocaval injury. For the majority of risk factors examined, the prevalence was relatively low. Upon comparing injury characteristics between the two groups, we found that iliocaval injury patients were more likely to have a firearm mechanism, lower initial systolic blood pressure in the emergency department, higher total injury severity score, and concurrent head, spinal, and pelvic injuries. Patients with iliocaval injury were also much more likely to undergo hemorrhage control surgery within 24 hours of presentation, as well as iliocaval operative intervention, defined using ICD-10 codes for procedures involving the IVC and or iliac veins. They were also slightly less likely to receive VTE prophylaxis during their admission, and when they did receive it, initiation was delayed compared to the group of patients without iliocaval injury. Of patients with iliocaval injury who underwent an iliocaval operation, 64% underwent repair only, 26% underwent ligation only, and 10% underwent other interventions. For primary outcomes, patients with iliocaval injury had a markedly higher rate of venous thromboembolism, defined as either a DVT or a PE, 24-hour mortality, and in-hospital mortality. Among patients who had iliocaval surgery, there was no difference in VTE rate based on whether they underwent repair or ligation. Unadjusted analysis of secondary outcomes showed that patients with iliocaval injury had significantly higher rates of cardiac complications, acute kidney injury, extremity compartment syndrome, and unplanned return to the operating room, as well as total hospital length of stay in days among survivors. After performing multivariable logistic regression modeling and controlling for the listed covariates, we found that penetrating iliocaval injury was associated with an independent increase in risk of VTE with an odds ratio of 2.5. Similarly, we observed a striking increase in independent risk of in-hospital mortality with an odds ratio of 9.6. In summary, iliocaval injuries are uncommon, occurring in less than 5% of penetrating abdominal trauma. However, patients with penetrating iliocaval injuries tend to be younger and are more likely to have firearm injuries with complex injury patterns and severe associated injuries. These patients often require venous repair or ligation. Additionally, the presence of iliocaval injury is independently associated with increased mortality and venous thromboembolic complications. To conclude, for penetrating abdominal trauma, iliocaval injuries are often seen in patients with severe multisystem trauma. Regardless of type of surgical intervention, survivors of penetrating iliocaval injury should be considered at high risk for developing venous thromboembolism. Providers should therefore adhere to prophylactic measures for preventing venous thromboembolism and have a low threshold to perform diagnostic imaging. Thank you for your time.
Thank you, Dr. Haqqani. Excellent presentation. I want to start with one question on my own, and then a whole bunch of people have already chimed in. Did you have any data on the number of VTEs that ended up causing some clinically significant finding, whether that be a PE or the need for anticoagulation that then ran into a whole issue with return to OR for bleeding and those sorts of things?
That's an excellent question. And we did not specifically stratify based on severity of the venous thromboembolic event and associated complications. We looked at the individual complications separately, but that is certainly something we will try to parse out further in our manuscript.
Okay, so my co-moderator Max has brought up a question which I think is very similar to one that I had listed as well. And it's some of the findings may be related to iliocaval injury kind of being a surrogate marker for very, very severe injury. And I had written your association with neurologic injury, which in and of itself is also a major risk factor for VTE development. Your thoughts on that is really iliocaval is kind of a surrogate, and really it's a whole host of factors, including the coagulopathy and the prolonged bed rest and those sorts of things.
Again, you are absolutely correct. Our data does show that patients with iliocaval injuries did have more severe injury patterns than those without iliocaval injury, including concurrent head trauma, spinal cord trauma, pelvic fractures. We controlled for some of these in our logistic regression, specifically the head, spinal cord, and pelvic trauma, but you are correct. We can't account for all the differences in injury severity.
Okay, so we got a few more minutes, so you get to be in the hot seat a little longer. Jordan Stern wants to know, for those who underwent repair, are you able to distinguish between the types of reconstruction, patch versus interposition, primary repair, and those sorts of things?
So when we looked at the types of intervention, we used the ICD-10 codes for iliac vein and IVC intervention, but the ICD-10 codes themselves, unfortunately, are not detailed enough to parse out the specifics of the type of intervention.
Okay, and then Greg McGee has a question here, which I think correlates with another one down below. So did you evaluate the impact of how the venous injuries were managed? I believe you did, repair versus ligation. And so based on that analysis, would you recommend anticoagulation after repair or ligation of these vein injuries? And then he also wanted to know to explain why ligation and repair resulted in the same rates.
So in our crude analysis, we didn't find any difference in venous thromboembolism based on repair versus ligation. But this was not the focus of our study, so we didn't analyze that through multivariable logistic regression. And
okay.
As for the question regarding anticoagulation, based on our data, we cannot make conclusions about therapeutic anticoagulation. However, we can fairly confidently say that whether repair or ligation is performed, penetrating ilioceval injuries are associated with very high rates of venous thromboembolism. And so timely DVT prophylaxis is something to definitely consider, as well as having a low threshold for diagnostic imaging and workup of suspected venous thromboembolism.
Okay. And Jeannie Reddy is asking, did you consider propensity matching these groups since you did have differences in the demographics?
So again, this is a good question. We did not for the purpose of this presentation, but that is certainly something we're considering for the manuscript. And we accounted for some of the differences in demographics that were statistically significant in our multivariable logistic regression analysis.
Okay, Karan Garg, did you assess whether VT increased complication rates in these trauma patients? So similar to the question about whether they end up being clinically significant. Did you assess any other complications that were associated with the VT, or not really part of the study?
We did not evaluate complications following the venous thromboembolism. Our focus was to look at complications associated with the injury itself, the primary complication being venous thromboembolism. But our secondary outcomes that were also significantly increased in these patients were acute kidney injury, extremity compartment syndrome, unplanned return to the operating room. And based on our data, we cannot conclude that these were influenced by the venous thromboembolism, but they are definitely related to the penetrating ilioceval injury.
Okay, one final comment for me, like your thoughts on the clinical take-home message for the group here. These patients, high bleeding risk, coagulopathy, they're pretty sick. So you're still advocating for early prophylactic anticoagulation to try to prevent the VTEs, other options you might pursue in these patients. What are your thoughts?
So the decision of whether or not to anticoagulate should be based on the individual's bleeding risk. And often with patients with severe polytrauma, this can be a difficult decision. Our data shows that these concerns regarding bleeding risk and coagulopathy should be balanced by the significantly higher rates of VTE found in this particular patient population. But unfortunately, our data isn't detailed enough to estimate the bleeding risk. The main takeaways that we can offer are that both trauma and vascular surgeons should recognize the complications associated with penetrating ilioceval injuries and have a low threshold for starting venous thromboembolism prophylaxis, as well as working up suspected thromboembolic complications.
Great, thank you. Excellent presentation.